Welcome to today's Explainer. We're diving straight into pediatric hip pathologies to uncover the mechanics, the mysteries, and the management of a really fascinating condition, Legg's Calvé Perthes disease. Whether you're a nursing student, a healthcare pro, or just someone who loves figuring out how the human body works and heals, we're going to break down exactly what happens when a child's growing bone is suddenly starved of its blood supply.
Here's our roadmap for today. We'll quickly cover the anatomy of LCPD, walk through the 4 stages of the disease, look at how to recognize the signs, discuss treatment and containment, and finally, wrap up with nursing and supportive care.
Let's jump right into Section 1, the anatomy of LCPD. To really grasp what's going on here, we've got to understand the environment it attacks.
So the absolute key takeaway here is that Legg-Calvé Perthes disease, or LCPD, is an ischemic avascular necrosis. Now let's unpack that a bit. For reasons we honestly still don't fully understand, there's a temporary disturbance of circulation to the femoral capital epiphysis. Basically, that's the ball right at the top of the thigh bone. You see, during middle childhood, the circulation to this specific area is actually pretty tenuous. It's fragile. And when that blood supply gets cut off, well, it essentially starves the head of the femur, leading straight to ischemic bone death. You might be wondering who is actually most at risk for this. Well, this huge 4-to-1 ratio really tells the story of the male to female incidence. LCPD most commonly strikes boys, usually between the ages of 4 and 8. To give you a bit more context on the demographics, Caucasian children are affected about 10 times more frequently than African American children. And here's a wild fact. In about 10% of cases, the condition is bilateral, which means it unfortunately affects both hips at the exact same time.
Moving on to Section 2, the 4 stages. Let's take a look at how this disease actually builds over a pretty grueling 18-month to multi-year span.
As you can probably guess, this is absolutely not a quick fix. First up, in the initial avascular stage, the bone actually starts to flatten as it essentially dies. Next, it fragments and collapses completely during the fragmentation, or resorptive stage. But then, as the blood supply miraculously starts to return, the bone slowly begins to calcify again in the reossification stage. And finally, it remodels itself all the way until skeletal maturity during the healing stage. It's a massive, massive process.
Now, clinical radiographs track this exact progression perfectly. In stage 1, if you're looking at the imaging, you'll spot a distinct decrease in the height of the femoral head. By stage 2, you start to see this mottled, almost patchy appearance on the X-ray, and that's directly due to the bone fragmentation. Then, moving into stage 3, there's increased density where brand new bone is literally filling in from the outside edges toward the center. And finally, stage 4 shows the gradual reformation of the femur's head. Honestly, this whole disease process is just a remarkable testament to the body's ability to rebuild itself. But, and this is a big but, that newly reformed bone can end up severely altered if it's not managed properly right from the start.
Okay, Section 3, recognizing the signs. So, how does all this invisible internal damage actually present in a real-life child?
The tricky thing here is that the onset of this disease is incredibly insidious. It's just super sneaky. Parents might just notice an intermittent limp or maybe hear some vague complaints of hip soreness or stiffness. And here's why that happens. Because that soft, ischemic bone is getting all these tiny microfractures just from normal daily activity. The pain and the limp become way more pronounced right at the end of a long day of playing, or sometimes right when the child first wakes up in the morning.
Now pay close attention to this, because this is a massive red flag. Hip issues actually love to disguise themselves as knee, groin, or thigh pain. You're probably wondering why. Well, it all comes down to the obturator nerve, which refers at hip pain all the way down the leg. What this means in practice is that any time a child comes in with mysterious knee or groin pain, doing a complete hip exam is absolutely paramount. You have to rule out an underlying issue like LCPD.
Just to give us a bit of differential context, let's compare LCPD to SCFE, which stands for slipped capital femoral epiphysis. Now, SCFE is another hip issue that causes a limp and that same referred knee pain we just talked about. But here's the difference. It typically strikes slightly older kids, usually between ages 8 and 15, right during those accelerated growth spurts in puberty. In SCFE, the femoral neck literally slips out of place, and it's often associated with obesity putting extra stress on the growth plate. LCPD, on the flip side, usually shows up in much younger kids. And remember, it's purely an avascular necrosis issue, a blood supply problem.
All right, Section 4, treatment and containment.
Let's dive into how we actually tackle this problem and protect that super fragile healing bone.
When it comes to LCPD, early treatment is absolutely vital. The ultimate outcome for the child heavily depends on jumping in with efficient management right away. The main goal here is containment. We want to keep that femoral head perfectly contained within the acetabulum, which is just the medical term for the hip socket. The idea is that as the bone heals and remodels, the socket acts like a mold, helping it maintain a nice, smooth, well-rounded shape. Now, kids under 5 usually have the best prognosis because their bones are a lot more cartilaginous and adaptable. But for kids diagnosed over the age of 8, the risk of developing severe degenerative arthritis later in life is pretty significant if that femoral head ends up collapsing.
So, let's walk through the actual steps of care. First things first, we start by severely limiting weight bearing. This is crucial to get the inflammation and irritability in the hip joint to calm down. At the same time, we're managing the pain with standard NSAIDs like ibuprofen and relying heavily on physical therapy to maintain the joint's range of motion. Then, to actually achieve that crucial containment we just talked about, healthcare providers might step things up to abduction braces or even specialized casting. And if all that conservative management just isn't enough to keep the bone properly contained, surgical reconstruction, like a pelvic or proximal femoral osteotomy, becomes the necessary next step.
Bringing us to Section 5, Nursing and Supportive Care. Healing a bone takes a lot of time, and honestly, sitting still for that long takes a massive toll on an active child's body. Think about it like this. When we restrict a child's mobility just to save their hip, we inadvertently create new problems. So we have to actively work to prevent secondary musculoskeletal issues. You see, the everyday stress of walking and running is actually what maintains our bone strength. Without that normal stress, calcium literally starts leaving the bone, which leads to osteopenia and leaves them highly vulnerable to other fractures. On top of that, the collagen arrangements inside the body start to alter when joints aren't moving regularly. This creates dense, stiff tissues that can cause severe joint contractures.
And it's really a domino effect. Extended immobility affects the entire body, not just the skeletal system. A prolonged lack of movement severely impacts pretty much all of our basic everyday systemic functions.
Let's look at a couple of major examples here. For the urinary system, simply laying flat alters gravity, which makes voiding incredibly difficult and often leads to urinary retention. As caregivers, we have to stay on top of this by actively hydrating the child and making sure we position them upright to help them fully empty their bladder. Then there's the integumentary system, or the skin. Decreased circulation from not moving means tissue injury and bed sores are a major risk. The nursing action here has to be incredibly strict, turning the patient every 2 to 4 hours around the clock and utilizing pressure reduction mattresses to keep that skin intact.
But here's the reality of Legg Calvé Perthes disease. For the most part, these kids are treated entirely as outpatients. That means our absolute biggest job in healthcare is teaching the family how to maintain these incredibly strict activity limits at home. The parents and caregivers must fully comprehend the why behind these restrictions if we want to achieve that perfect, round hip socket we've been talking about. Our education, our communication, and our ongoing support are truly the anchors of this entire therapy.
I want to leave you with a bit of a provocative thought as we wrap up today's explainer. Imagine you have a child who, except for a slight limp or some occasional achiness, feels perfectly fine. They're energetic, they want to run, they want to jump, they want to play with their friends. Yet, medically, they must remain relatively inactive for months, sometimes even years. Treating the hip joint? Well, that's just the clinical side of the equation. Devising creative, totally safe activities for a restless child, activities that fulfill their natural urge to play and help them develop their sense of initiative without destroying their hip. Now that is the true art of care. Think about how you would handle that challenge in your own practice or home. Thank you so much for joining me on this deep dive into Legg Calvé Perthes disease, and as always, keep seeking out the why behind the clinical signs.